Hi, everyone. My name is Jason Phua, and I'm a respiratory physician as well as an intensivist in Singapore. Welcome to the Asia Ventilation Forum, or the AVF Podcast. This is the ICU Tips and Tricks series in which we invite experts to share anything and everything about how they deal with various clinical situations. And today we are really glad to have Professor Laurent Brochard. He is the Keenan Chair in Critical Care and Respiratory Medicine at St. Michael's Hospital and the University of Toronto. He's the head of the Division of Critical Care Medicine at the University of Toronto. He's also the deputy editor of the Blue Journal, or the American Journal of the Respiratory and Critical Care Medicine, as well as former editor-in-chief of Intensive Care Medicine. He's the head of the PLUG Working Group on Pleural Pressure for the European Society of Intensive Care Medicine. He's the former head and member of the REVA, or the European Research Network on Mechanical Ventilation, and member of the Canadian Critical Care Clinical Trials Group. So he's well known to all of us. I think he's got more than 500 publications and something like more than 10,000 citations. And today he's going to share with us how he sets PEEP, or positive end-expiratory pressure, for patients with ARDS, or acute respiratory distress syndrome. So Prof. Brochard, thank you very much for being with us here today. I'll just...
Thank you for the invitation, Jason.
Thank you. Maybe I'll just start with the basics. Like, why do we even set PEEP for ARDS, and what are the problems if the PEEP is set too high or too low?
Well, that's a fantastic question, because this is the type of question we should always have in mind. And, and again, we are talking of patients with ARDS, with bilateral lung injury. If you don't intubate these patients, some of them, they will die of diaphragmatic fatigue or hypoxemia. So you need intubation. With intubation, you give sedation, you create atelectasis, and if you don't give any PEEP, the patient may again die because of right ventricular failure or hypoxemia. And we tend to forget that PEEP is so important. Does not need to be a high level, but some PEEP to combat some atelectasis, that's very important. The point is that, so that's what could happen if you don't put enough PEEP. For instance, if you go for zero PEEP, that's atelectasis and right ventricular afterload will be excessive. And of course, hypoxemia may also be an issue. But if you put too much PEEP, and I will discuss what it means, you will mostly distend the already aerated part of the lung. So you put the lung of the patient at risk of excessive distension. And again, because you compress the capillaries, you increase the right ventricular afterload, and you may also increase the risk of right ventricular failure. So that's a really tricky issue. I think we always need some minimal PEEP, but the question is how much we can go up to help keeping the lung open. And the reason why we want to do that is because we think that opening and closing the lung at each cycle is probably very bad. It's causing what is called atelectrauma. So basically, to answer your question, there are two main reasons. The first one is to combat minimal atelectasis due to intubation, lying supine, and sedation. And the second one is to keep the lung open when it's recruitable, because it's bad to open and close all the time. And this goes with oxygenation usually, but it's not perfectly aligned with oxygenation. So as clinicians, we often think about oxygenation, but I think we should think of the other reason why we should use PEEP.
Right, thanks. So the 2017 ATS, ESICM, as well as SCCM guidelines, they suggest that adult patients they receive moderate, I mean, with moderate or severe ARDS, that they receive higher rather than lower levels of PEEP. I think I'm quoting the actual language, but
Yeah.
but what is the meaning of higher versus lower? What kind of PEEP levels are higher versus what kind of levels are lower?
Yeah, that's a very practical question, and there is some confusion here. I think the language was the same than you remember, higher versus lower tidal volume. That was the same, but we had fixed numbers. So if you look at the main trials, except the most recent one, which I will describe, I would say the cutoff is probably around 12 centimeters of water. So I would say anything about 12 is high PEEP. So let's say 12 to 15, for instance, and anything below, let's say around 8 to 10 is low PEEP. So that's the basic reasoning, and the recommendation were based on the studies which show that 8 to 10 is probably okay for the mild ARDS, whereas you may need to be 12 to 15, especially moderate to severe and severe. The last study, which was the ARDS trial by the Brazilian group, I would say compared high to very high, because in their trial, the low PEEP arm was close to 12. So, and they found that high versus very high was bad, was clearly bad. I think they had really safety issue with the recruitment maneuvers, which were very risky and dangerous. And they also said very high PEEP based on driving pressure, which can be really misleading. I can explain why. And that gives really the idea that the PEEP is like a U shape, and too low is bad, too high is high. And you need individually to find where is the good spot. And if you want numbers, I would say low is around 8 to 10, high is 12 to 15, very high is above that.
Right. It strikes me that you said that high is 12 to 15 and very high is above that. And I'm referring to the PEEP to FiO2 tables.
Yeah.
And we know that we use them quite frequently, and there's the low PEEP protocol and the high PEEP protocol. But even the low PEEP protocol, quote unquote, easily goes above 15 and it goes up to 24. I just wanted to hear your thoughts about these PEEP to FiO2 tables. Are they validated? Are they worth using?
Exactly. So that's a good point. The two PEEP FiO2 tables go up to 24. And I think, when you have nothing to assess the lung recruitability at the bedside, you do with the best surrogate you have, which is the oxygenation. And oxygenation is really problematic because since the 1980s, it was very nicely shown that when you decrease cardiac output because of PEEP, the decrease in cardiac output decrease the blood flow going to shunt. So decreasing cardiac output will improve your oxygenation. And this has nothing to do with recruitment. So that's a problem. Another problem is that we've done a study where we measured the presence of intracardiac shunting, patent foramen ovale, and 20% of patients with ARDS had significant shunting. And again, so it may go the opposite direction, because you may recruit the lung, improve the recruitment, but worsen the intracardiac shunt and worsen oxygenation. So oxygenation is really not a very good surrogate. And this is one of the problems with the PEEP FiO2 table. So I would say, if you have nothing else, maybe that's okay, but that's really not a very sophisticated or smart way to individualize. I think we can do better.
Right. So you are a believer of individualization of PEEP.
Yes.
Yes. And could you talk us through some of the methods commonly used and whether there's any evidence for them?
Yeah, so
Yeah.
I mentioned oxygenation and all the problems, and in fact there are very few studies which compare the oxygenation and the true recruitment measured by different techniques, and the correlation is very weak, as I said. The other technique is to look at compliance, and again there are many issues. One of them is that naturally, when you increase lung volume, you expect a decrease in compliance. That's normal. And therefore, to interpret that, for instance, compliance does not change or even slightly decrease, what does it mean? You may still have recruitment. So that's complicated. Last, if you have tidal recruitment, you know what we try to avoid, opening and closing, this will make your compliance looking better, looking good, because you recruit at each breath. So it looks a good compliance, but it's not good for the lung. It may be better to completely recruit the lung and have a lower compliance. So compliance is, again, not very good. That's why we have been working on a technique which could be used at the bedside. So for many years, we did studies with pressure volume curves, because they can tell us whether the lung has a hysteresis behavior, which means once you have recruited, you don't come back to the same level of volume, but for the same pressure, you have more volume because you have reopened some lungs. So that's okay, that's fine, that's well correlated with some CT scan techniques, but that's a bit still complicated. So we simplified it to make manoeuvre which very quickly can tell you whether the lung is mostly recruitable or mostly non-recruitable. And once you know that, you know which direction you go. You know, the low PEEP around 8 to 10 or the high PEEP around 12 to 15. And we do that in one single manoeuvre. So you have to be sure the patient is completely passive, because the patient is breathing, that's an issue. And you measure the trapped volume by PEEP. Okay, in one breath, you release the PEEP. What we do usually is from 15, we go to 5 in one expiration. And therefore, the volume expired, which is measured on the ventilator, is the tidal volume you set plus the trapped volume. And this trapped volume you can compare to the volume predicted by the compliance at low PEEP. If the compliance at low PEEP, so the compliance of the baby lung, tells you that with 10 of PEEP, you should increase your lung volume by 200 because the compliance is 20, you know that that should be the trapped volume if there is no recruitment. If you measure 400, it means, well, your PEEP recruited. And from that, we make a calculation, which is the recruitment to inflation ratio, which tells you how much of the inflation goes into the baby lung, how much go into the recruited lung. So we have a web page called rtmaven.com, which is free, open, where we have short video explaining how to do it. Really, it's 1 minute, and I can tell you, in the ICU now, we do it as soon as patients are intubated. All the respiratory therapists know the manoeuvre. It's very simple, and even in COVID, for a COVID patient, it was done all the time, and you can repeat it as much as you want. So it does not tell you exactly what's the best PEEP, but it tells you the lung is mostly recruitable, so try to increase the PEEP, and maybe until you reach a safe plateau pressure, for instance, or no, the lung is not recruitable, so try to set the PEEP as low as possible, what is acceptable for oxygenation. So this is how we do today, and really I encourage people to to use that. Is it validated? Well, we are running a randomized control trial to try to see if it changed the outcome. We validated already with a number of tools like other parameters of recruitment, but as you know, no one is perfect. So we think it makes sense. We think it helps to individualize, and that's the approach we have now.
Right, thanks. That's fascinating. So you have a high PEEP, you drop the PEEP to a low PEEP, you look at the air over and above what you would expect beyond the tidal volume.
Exactly.
So you calculate this recruitment to inflation ratio, and above a certain value, you will set a higher PEEP, and below a certain value, you will set a lower PEEP.
Exactly. And
right.
The web page we offer as a calculator, so it makes it easy to, you just enter the value, it gives you the ratio directly.
Right. And when you say you set a higher PEEP and a lower PEEP, is it what you said just now, 12 to 15 versus 8 to 10?
So we standardized it, and we always do 15 to 5.
Oh, okay, 15. That's the maneuver.
Yes.
But what I meant is, after you have determined the ratio, and the more recruitable patients, what kind of PEEP would you set versus the less recruitable patients?
Yeah. So we know which direction to go, higher PEEP or lower PEEP, and then we look at the other parameters, right? What is the plateau pressure? What is the driving pressure? What is the hemodynamic tolerance? So we decide based on that, but we know whether it's worth to try to increase the PEEP or to try to maintain it the lowest possible. And if you think of the randomized trials, all of them compared high PEEP strategy to a low PEEP strategy. Our technique would say in the high PEEP group, there is at least half of the patients who do not need high PEEP, and maybe the opposite in the low PEEP group. So I think the trials now, have not been adequately designed. Even we can understand why, and I think we can find better results.
Thanks. I'll come back to this technique again. But if I could go off on a slight tangent, so how about the other techniques that we see being used, using ultrasound or CT scans or esophageal probes or stress index, etc. Yeah.
Okay, great. So CT scan is great, is fantastic. It's impossible to use it clinically, really, because, well, okay, you have to transport the patient to the CT. You have to do several levels of pressure and do the CT at different PEEP levels or different pressure. And the data shown by Gattinoni, for instance, are beautiful. They compared CT scan done at 5 centimeters of water and at 45. And they really show that some lungs can be reopened, some lungs cannot. That's not exactly the question you want, because it's okay to reopen, but you want to know which PEEP level you need to maintain to keep it open, right? So that's another question. So, and the main problem with the CT is that you really need, it's a very sophisticated and complicated analysis of the Hounsfield unit. So unfortunately, this is the best way to visualize it, but it's not feasible at the bedside. So you mentioned the esophageal probe. I like it very much. I think there is one very good indication, which, depending on the countries, may be more or less frequent. It's high BMI, obesity. And the reason is that in obesity, you have an additional factor explaining the decrease in lung volume, and it's a load imposed by the chest wall. So it is not a stiff chest wall. It's like having a big weight on your thorax. so the stiffness of the chest wall is normal, but you start from a high pressure. And the only way to really measure this pressure is to put an esophageal probe. And then you see that the pressure around the lung is, around 18 centimeters of water, 20, 22. And you need some PEEP to counteract this pressure. So in the obese patients, I really think, okay, you could do it without esophageal pressure, just blindly, but that's really a bit, you are much reassured to see the real value, and you may need much higher PEEP just for the reason not of the lung injury, but of the weight imposed by the chest wall. And it's absolutely remarkable that in some very obese patients, BMI more than 40, 45, or the hemodynamic tolerance of PEEP is absolutely remarkable. You increase PEEP, and nothing happens in terms of blood pressure. So indicating that they really need this positive pressure to counteract the. So I think it's a very good indication of the esophageal probe.
Right, thank you. And so going back to how you do it, you said that these patients need to be paralyzed and or at least really sedated. But say it's day 2 or day 3 and you are weaning the sedation. Do you repeat the maneuver or what?
Yeah, so that's a very good point. So as soon as the patient start to breathe spontaneously, the maneuver becomes very difficult. And so the question is, do you give a bolus of sedation just to do it, or even a bolus of paralysis? So usually we don't, so we don't repeat it. But sometimes we are not happy with the way the patient is doing. We find the drive of the patient is very high. We measure the occlusion pressure, the P01. And then we say, okay, maybe this patient still needs very high PEEP, so we can give a bolus of sedation and maybe paralysis just to measure. But that's a limitation for sure. The point is that I think when patients are breathing spontaneously and you have troubles because they are working really hard, it may be important to keep the PEEP relatively high. Again, if you have some marker of persisting lung injury, you think it's still the lung is still bad, the PEEP may be helpful to keep the work of breathing a bit lower, but it varies a lot between patients. So that's a very difficult phase when you start spontaneous breathing and they have a high work of breathing.
And so if you've decided that, say the P01 is not that high and you've decided not to sedate or continue neuromuscular blockade, and you think that the patient is clinically getting better, but you don't really have a sense of the recruitment inflation ratio. So say the PEEP is 12 at that point. What do you do? Right. You arbitrarily down it by a few hours, a few cm H2O per hour or something?
Yeah, I think we do the philosophy of the general philosophy of winning, that you need to try. You need to try whether it's tolerated or not. And I know you may worsen a patient quickly by going too fast, so you may be careful, and that's about the clinical judgment, right? There is no real protocol there. We have shown experimentally, for instance, that dropping PEEP very abruptly can induce a rapid increase in blood flow without the time for an adequate vasoreactivity. So this may induce pulmonary edema, right? So you may have to go a bit gradually, but you have to try. Otherwise, you won't know. So nothing systematic, but just have the philosophy to try to see what the patient would do with less support.
Right. Thanks. I also wanted to ask you, because I remember you spoke about driving pressure just now.
Yeah,
And we often get this, right? We have patients that we think we are at optimal PEEP. So we
yeah,
fix it at that certain level, and yet the plateau pressure exceeds the magic
yeah,
30 cm H2O. So we have several options, right? We reduce the tidal volume, or we reduce the PEEP, or we think about driving pressure. But so how do you
yeah,
approach this situation?
yeah. So first thing is that I love driving pressure. I think it's very important, but it's especially very important for tidal volume. So what I mean is that it's not a good indicator for precisely titrating the PEEP. And there are many reasons. It's the same reason I spoke about when I spoke about compliance. Okay, you may have a better driving pressure because you have tidal recruitment. So that's not great. And in addition, the driving pressure and the compliance tend to reflect more the dependent part of the lung. So you may not see what's happening in the non-dependent parts. So again, just to make simple, driving pressure, fantastic, especially for titrating the tidal volume, not so much the PEEP. However, as you say, you may have still a high plateau pressure. So I would say you have a high plateau pressure, but your driving pressure is okay. And you, the question is there a reason for having high pressure, like obesity, for instance? And then, is it possible to safely decrease the tidal volume? Because I have room to. It's easy to increase the respiratory rate, and my pH is good, even if my PCO2 is slightly high. So yes, I would go for decreasing slightly the tidal volume, because the price to pay seems to be low. I know it's not good to increase too much the respiratory rate, but the combination of high volume, low rate, and lower volume, high rate, it's in favor of lower volume, high rate. Of course, you try to limit and not to increase the rate too much, but that's still worse. So I would try to see if tidal volume can be decreased. If not, if you're already with acidosis, or if you're very close to the dead space of the patient, yeah, the next thing to do is decrease the PEEP. And the last thing is to remember, well, there are a number of patients where we cannot offer a perfect ventilation. We know that, right? It doesn't mean they will die. It means they are more at risk. But so that's a kind of trade-off between the different risks.
Right. Got it, Prof. So last question is whether you have any last final words or advice for anyone out there who's listening on this whole issue of PEEP in ARDS.
I would say, so don't think first about oxygenation, but think about what you do with the lung. Think about using our index, because again, it has been designed for being used anywhere with any ventilator, and it's relatively simple. And use your clinical judgment, because there is no magic recipe which will work for every patient. And this is why we need intensivist and good respiratory therapist in the ICU, and that's why it's such a fascinating job.
Right. Thanks a lot, Prof. And on that note, I just want to say once again, thank you for spending time with us. I am 100% sure that many people out there would be so fascinated about this talk, and we'll take your advice, and tomorrow we'll try it in the ICU. So thanks a lot.
Okay.
Prof. Yeah. So to everyone out there, I hope that you have liked this podcast. And if you have, just remember to like it, or to follow it, or to subscribe, or to share with your friends. It's available on Spotify as well as YouTube. And some of the studies that Prof quoted just now, we will be attaching the links, including the rtmaven.com website that he spoke about, so that everyone can try it out. So this AVF podcast is the third in our series. There are more to come. So we'll see you again very soon. Take care. Bye.